Let me begin by thanking Mike and Ollie. Thank you so much for having me here. It's a pleasure and an honor to be part of the very first Ditron conference. And my topic, biologically driven dental implant abutment design, I hope you'll enjoy. In order to begin this presentation, I want to take you on a journey, what I call the emergence profile memory lane. So I'm going to get right into it. So this is Cynthia, and Cynthia presented back in 2009 with a failed number 8, and this is her outcome, an implant restoration in that area in 2010. Now, doctors, that turned out pretty good. It definitely didn't happen by magic. It was an immediate placement, connective tissue graft, it was covered up, and then uncovered, delayed provisional tissue shaping in order to get that outcome. And this is what it looked like at the time of uncovery. So there's a lot of tissue shaping that needs to occur. That's the prototype, it's a screw-retained prototype after tissue shaping and maturation. Took a long time, took several months to get all the tissue to develop and grow to where it needed to be. So this is what it looked like before the provisionalization and after. This is the tissue shaping and what that whole area looked like after the tissue was shaped. It turned out pretty good with the provisional phase. And then in 2009, 2010, this was my protocol. I would reproduce that emergence profile, develop a custom impression post. These are techniques you're very familiar with. And take an impression. At that time, I did a CAD-CAM abutment, a zirconia abutment. And the reason why is because of the translucent nature of the adjacent tooth. I needed to match that adjacent tooth and also reproduce those white hyperplastic features on the enamel. Then made a lithium disilicate laid restoration, cement on. And after a couple try-ins, that's the outcome. And it turned out pretty good. I was quite happy with the outcome, so was the patient. And the x-ray looked okay. You know, I looked at that x-ray, I thought, yeah, that looks pretty good. It's what I would expect for this kind of treatment. Until I had a closer look. The beauty of putting presentations together, you get a closer look at your work. And I noticed something about the remodeling of the bone at the implant abutment interface. I noticed that that remodeling or the bone resorption tended to follow the dimensions and the shape of the abutment as it emerges out of the implant. But when I had a closer look at the provisional, the x-ray I took when I placed that provisional, that's the titanium provisional abutment, there was more bone over the top of that platform switched implant. And we all know that when you uncover an implant, you expect the bone to resorb away to the biologic width characteristics of that particular implant design. So I didn't think much of it at the time. But then I paid a closer attention to the shape of these components. So when I had a look at the shape of that titanium abutment, it has a lip on it. It has an immediate emergence to it, same as the lip on a zirconia abutment. Then when I had a closer look at the impression post has a lip on it. And of course, so does the abutment itself. Still turned out good. Let me introduce you to Bo. So Bo, around the same time, I met Bo in 2008, failed 8 and 9, immediate placement simultaneous, and that's the outcome. Turned out pretty good. Made him a little bit longer, bleached his teeth. Anyway, happy with the outcome, so was Bo. And this is what Bo looked like when we finished treatment. But then again, let's compare the x-rays of prior to extraction and then completed dentistry. We lost a couple millimeters of interproximal bone, as you would expect from remodeling. But I was so stoked in 2010, having just 1.5 millimeters of coronal bone above those platforms. I thought that was really cool, because usually I saw the bone flatten out to the level of the abutment platform. I didn't see it in this case. I thought that was an excellent outcome. Until I had a closer look at these radiographs, again, I noticed the same thing, remodeling, right? Bone resorption, remodeling, we call it. And it tended to follow the pattern of the emergence profile of the components. Now, let's have a look at the radiographs of when those implants were uncovered. So the implants were uncovered, and I took impressions, made prototypes. They're the titanium cylinders. In fact, I had to modify those titanium cylinders to be able to get it onto the implant platform because there was so much bone there. And there was a lot of bone, right? So I made these provisionals, and I know that bone's going to remodel. I know it's going to melt away. And as it melts away, we're going to lose interproximal peak of bone. As we lose interproximal peak of bone, we're going to lose that papilla, and there's going to be a black triangle. So I'm going to keep bone in a prototype phase for at least 12 months to allow that remodeling to occur. So this was the protocol I was following at the time. So let's have a look at the bone levels at the times the prototypes are put in. And this is the bone levels 12 months later. All that remodeling, right? I expected that to happen. No, because these abutments have a biologic width also. Not only does the implant platform, implant design have a biologic width, so do the abutments. The bones are going to want to remodel to allow for a specific layer of connective tissue and epithelium. So that was kind of the protocol at the time. So, but let's have a closer look again. So that's the time I placed the implants prototypes in. Now have a look at the soft tissue over 12 months. So pay attention to the soft tissue interproximal on 8 and 9. That's what we expect. So now 12 months later, I can make the definitive restorations, make the contact area a little bit longer to close that gap, right? God forbid we give the patient a black triangle. So that's the outcome. Turned out pretty good. I was pretty happy with it, but I kept thinking in the early 2010s, I kept thinking, what if rather than accept those components from the manufacturer, what if every single component from the time of uncovery or implant placement didn't have a lip on it? It had more that shape. At zero emergence profile for the first 1 to 2 millimeters, what would happen? Would that preserve more peri-implant tissue? Would that preserve more bone, connective tissue? And would that preservation of tissue provide a better peri-implant seal and a better aesthetic and long-term implant outcome? Would that help the overall outcome and health of those peri-implant tissues? Same with Cynthia. What if with Cynthia, rather than accept that design, there was a zero emergence profile, but not at the end of the treatment, at the beginning of the treatment, every single component, the healing abutment, the impression post, the titanium cylinders, and a definitive abutment. What if? Would that preserve more bone? All right, so that's the preface, and that's the question. I started to change the way I restored implants in around 2013. And I'm going to use Michael as an example to test this hypothesis. Michael comes into the office. He's a young fella, and he was mountain biking in Vail, and he was drinking, and not a good combination. So he fell on his face, he broke his teeth, and he's got a pulp exposure in 8, and 9 is not very good. But there's a lot of tissue there that we can preserve, right? So I did a bit of triage on the first day, did a composite restoration. Eventually, that's going to be a veneer. It's going to have a root canal and a veneer. And I planned a case out to see whether there's a candidate for an immediate implant, and he is. But he's not a candidate for a tooth, in my opinion. But still, there's a lot of advantages to minimal dentistry in this zone. So what I'm going to do for him is a little bit different. This is a protocol back in the day. It's very similar today. Made a guide for a guided osteotomy. Took the tooth out, placed the implant, got good primary stability, and grafted a gap with a xenograft, BIOS. But rather than make him a whole tooth, I made him a half a tooth. And I did something different with this half a tooth. The titanium abutment that I used to make a custom healing abutment had a lip very similar to the lips I showed you on the previous cases. Decided to get rid of that lip. So I removed the lip and just polished that metal. So I have a zero emergence profile for the first 1 to 1.5 millimeters, and then I emerge out to fill the socket. And the reason I did this, I want to see whether by removing that lip and having a zero emergence profile, is that going to improve the biologic width potential of the implant and of the abutment itself. And what a better case, what an awesome case to try this concept out than in an immediate case, where there's a big gap there, and there's just around that implant head, and there's biomaterial, and there's blood, and nothing else. Is bone going to grow right up to that implant platform? So let's follow this case over. Of course, I made him a partial denture that wasn't putting any pressure on that healing abutment, and this is 6 months later. And it's looking pretty good, as you can see, 6 months later with this zero emergence concept. But what impressed me the most after 6 months is that there's still biomaterial, something over the top of that platform switched implant. Very different to the other cases that I showed you, just those other 2 cases. And then I made a prototype, bleached his teeth and developed the plan for him. And even the prototype's the same. Good bone levels, and then reproduced all that information for porcelain fused metal, screw retained restoration with the zero emergence profile concept and a veneer on the adjacent tooth. And it turned out quite well. We made a contact area between 8 and 9 longer because he didn't want a black triangle. He specifically requested that, and that's fine. That's fine, and it turned out great. So let's have a look at the x-rays now on these 2 restorations. It's a lot more biology on the top of that implant than the other cases I showed you. Much more biology. So let's test this hypothesis out a little bit further. And it's not just me that came up with these concepts. It's well reported in the literature of late, this biologically driven design, abutment design. But let's continue. I'm going to show you a couple other cases that I was trying to see whether this concept worked. Early cases. 2013, Joanne fractured a 2-unit bridge that was tooth supported on tooth number 11. She's a good candidate for an immediate implant, but she's a parafunctionist, so she's not a good candidate for an immediate tooth, but she is for an immediate custom abutment. Same thing, got a titanium cylinder. I removed the lip, so there's a zero emergence profile for the first 1 to 1.5 millimeters. Filled a gap with bovine, let it heal for 6 months, took an impression, made a prototype, 2-unit prototype bridge for her. And again, zero emergence profile for the first 1 to 1.5 millimeters. And then eventually reproduced all that and made her 2-unit restoration, exactly the same as she had prior to her fracture, but implant supported 2-unit restoration. And tissue-wise, there's some remodeling, of course, you're going to see that. But it turned out quite well. So that's reproduce all that information and make a porcelain fused metal, screw retain. This is porcelain fused gold, but a zero emergence profile or minimal emergence profile concept at the very first 1 to 1.5 millimeters. And it turned out pretty good. He's happy with the outcome. Now, the cool thing, but let's have a closer look at the radiographs. One thing you're going to notice about this particular radiograph, it's a non-implant platform switched implant. It's not platform switched, yet the bone tends to grow almost to the top of that implant platform. Now, unlike Michael didn't allow me to take a post-op CT scan, but she did. But this is 10 months after implant placement. And one thing you'll notice at the abutment implant connection, there's bone in the facial area. My question to everyone in the group is this. If I left any of those lips on those components, if I left the lip on the temporary titanium cylinder, would there be bone in that area? No, the bone will remodel away, right? To allow for connective tissue epithelium, because the implant components at the level of the implant also have a biologic width zone that needs to be accommodated. So that was the proof of concept. There's just 2 cases I showed you. Now I'm going to push the envelope even further. This is 2013. And I met this lovely lady in 2013. And her chief concern was her aesthetics. She had an endodontically treated tooth number 9. And it's still hanging in there, so we're not going to get rid of it. We're going to keep it, see how long we can keep this tooth, and 3 veneer restorations on adjacent teeth. So all lithium disilicate restorations, and it turned out really well for Anne. She's very happy with the outcome. Finished in 2013. Well, 9 years later, it finally gave up the ghost, right? Vertical root fracture, buccal plate got perfed. It's a disaster. Tooth is mobile. It doesn't look like it when you look under the hood. It looks fine. But the tooth is mobile, and it finally gave up the ghost. Now, the thing to know about Anne, she doesn't live in Denver, Colorado anymore. She lives in Arizona with her husband, Tom. And she's a bit of a dental phobe, and she's really anxious. And it would be awesome to be able to help her and keep this minimally invasive as well. I planned it out. There's actually enough apical bone for an implant. So how about testing this hypothesis in a difficult case like this? How about removing that, placing an implant, grafting at the same time with a zero emergence profile concept from start to finish? How well will that work out? Is that going to be predictable? Okay, so took the tooth out, cleaned everything out, got primary stability. Wasn't great, but it was okay, 25 to 30 newtons. And put in a cross-linked collagen membrane and grafted that gap, packed it full of BioOs and also allograft, 50-50 mix, and sutured it up. So a combination of 70-30 mineralized, demineralized, and also BioOs. And then I did this. Had a mat facing Mecca, the rabbi in the other room, rosary beads over here. And of course, I made her an Essex appliance so that it'll be no load on that area at all. So this is what it looks like at the time of doing the procedure. A lot of biomaterial, Essex appliance. And 6 months later, doing very well. It integrated, the bone still remodeling around that area, took an impression, made her a prototype. And as you can see from the prototype, it worked out well. I think what's remarkable about this is how well everything responded to this zero emergence concept and having, maximizing the potential of the implant itself. This is what a prototype looks like in September of last year. And this is what a tissue looks like in that area. Got five minutes? Okay, good. I'm going to rock and roll then so you can get to, and I think we'll be fine. And this is what the emergence profile and everything looks like. And it turned out really well. So does this work in a healed site? How well does it work in a healed site? A failed implant migrated, grafted the area, 50-50 bovine allograft, made a provisional, and placed an implant. Once it all healed up, that's the provisional with zero emergence profile. This means that every component had zero emergence profile. Every component, the healing abutment, the titanium abutment, and a definitive abutment. Here's a definitive restoration. Now, let's have a look at the bone. This is a non-platform switched implant. And as you can see, it turned out pretty amazing. Again, this is a healed site, so it works even better in a healed site. Turned out great. All right, this is what I want to share with you. This is the most important. This is the last case. This young lady unfortunately, was in a bar and she got hit in the face, altercation, tooth number 8's fractured. She just had ortho. Can't tell because she's got an open bite and some challenges there. Teeth, unfortunately, didn't survive very well from the ortho also. Very thin bone buccal lingually as well. So this 7, 8, 9, and 10, poor prognosis, especially 8's non-restorable. She's missing interproximal peaks of bone. She's missing soft tissue. So she was referred to me by Emilio Arguello. He's a periodontist in my community. And so what? Emilio removed that tooth, grafted. He also grafted a buccal area to give more buccal lingual dimensions with a buccal tunnel graft. And I made a provisional RPD. And this is what it looks like after all of that grafting healed. Buccal graft and also that number 8 site. And as you can see, those teeth have a very poor prognosis. Now, the hypothesis. What if we combine zero emergence profile concept from start to finish with an immediate placement? We place 4 implants. We use a modern implant design like the Ditron Ultimate. Can we preserve that interproximal tissue? Will this help to preserve the tissue so we can keep it a minimally invasive approach, preserve as much tissue as possible? Now, of course, we're not going to use those tooth positions. So planned it out for the correct tooth position, planned it out, can space these out 3 millimeters apart. These are the 3.75 Ultimate implants. Will the combination of these two concepts with a modern implant design, will it preserve tissue? She's got a high smile line. She's going to see tissue also. Can we avoid using pink, artificial pink, in a high smile line area by keeping it as conservative as possible. So I assisted Emilio in the surgery. It was guided and sort of guide assisted. The gap was filled with a cortical mineralized allograft and an Essex appliance. This is 6 months later. Notice the healing abutments have been modified so there's a zero emergence profile. So everything had a zero emergence profile. Now, we didn't quite get the implants exactly where we wanted. 2 of them were 2 millimeters apart, but at least the others were around 3.5. How well is this going to work at 2 millimeters apart with this concept? These are the prototypes after tissue shaping. I think you can see already that it's working quite well. We managed to preserve tissues. And the prototype phase, aesthetically, it works in her face. Of course, they're going to be longer. She had a huge open anterior bite. They're going to be narrower because she had crowding, and she accepted that. But the most important proof is in the pudding. The interproximal peaks of bones haven't changed so much, even with those adjacent implants that are 2 millimeters apart. Then I modified some CAD/CAM abutments that had the same emergence profile, opaqued those out and made monolithic restorations, EMAX, cemented those on, and delivered those to her just recently. Now let's have a look at the radiographs. There's a significant amount of interproximal biology above the implant platforms. Hasn't changed terribly much from when she had teeth. And when you have a closer look at that, the rise and fall is very similar. And the proof of the pudding is in the CT scan. You can see how much biology is still present and the volume of the biology that's still present above the implant abutment connection because of utilizing a zero emergence profile from very beginning to the very end. And when we have a close look at just 2 of those implants, that's a lot of biology. And what's remarkable about this case is that when you combine biologically driven abutment design with pretty amazing dental implant, you can achieve remarkable results. Doctors, I hope this has given you some new perspective on the role of the abutment in a relationship with implant design. Thank you very much.